Sure. I will move over to, I've never been good at this aspect of technology of switching to my slides. Hold on, please. There we go. So given that this is a fairly broad audience of clinicians who may be involved in primary care or not specifically psychiatric care per se, and because depression is a very common condition and potentially a very serious condition, certainly is disruptive and debilitating, and as this audience knows, is associated with increased risk for suicide. It's a big thing. And the dominant explanation for depression is that it is some kind of chemical imbalance. We could probably do a whole lecture about how we came to that um, conception of depression, but I will explain a little bit about how I think thinking of depression as a chemical imbalance is problematic. And I will offer perhaps a broader view of depression, including a different way. There are probably different ways. There are probably many ways to think about depression, but I'd like to propose thinking about depression as a memory imbalance or a cognition imbalance, simply because we can actually measure that and demonstrate it quite reliably. And I think that offers up interesting ways for people with depression to think about themselves and their futures, and for clinicians to think about the administration of care for depression affected individuals. I, in some earlier version of this kind of talk, I came up with this idea that the mind needs and demands explanation similar to the need of brain cells for oxygen. We human beings cannot go for a second without, in our mind someplace, a story of how we are, where we are, why we are where we are, and the brain does this because the brain primarily is a survival organ. I mean, the brain's top job is to promote the survival of its human. And human brains, the human survival strategy involves a lot of reason and some ability to predict what might happen next. Thus, I think the need for having a constant story in the background to explain how I got here, and therefore what I might be looking out for in the minutes or hours to come in the future. So that's one thing that I don't think, I mean, the need for story is extremely important and worth emphasizing. The other thing that I think is extremely important and worth emphasizing is how simple words or simple stories can have very big impacts on how we think of ourselves and how our futures might turn out to be. I want to just introduce you or try to impress you with a few examples that illustrate the often unappreciated power of subtle variations of language. There was a study of 485 individuals. They were asked to pretend that they were the mayor of a make-believe city, and they were going to get a briefing on crime and be asked to make some decisions about how to address crime in their city. And they were given a paragraph, 80 words, identical paragraphs to both groups. The only difference was that in group A, crime was described in the metaphor of a beast ravaging the city. And in group B, crime was described as a virus that was ravaging the city. And then they asked, how would you deal with the crime issue in your town? And the ones that had been exposed to the virus motif or metaphor significantly thought that we should do some kind of reform or surveillance or public health measures. And the ones that had been primed to think of crime as a beast significantly chose to treat it with toughness and enforcement, as you might, be forceful with a beast. And the thing that was, I think, also very striking about this study is that only 3 people, or 3% of the sample, correctly identified or linked that their decision had anything to do with the metaphor that they sort of read 80 words prior to their decision making. Significant influence of metaphor. simple metaphor. Similarly, we can do studies where we imagine people to, where we ask people to imagine a hypothetical patient Joe who's been diagnosed with cancer, and we can tell the people who are thinking about Joe's condition that he is either battling cancer or journeying with cancer. And the likelihood that Joe is going to feel guilty or make peace, it was, again, very significantly influenced by whether the group thought that he was battling or journeying. And in Spanish language, you can have a concept of locura, which is roughly insanity or mental unwellness or mental illness of some kind. And it could be described as entering, I'll say, madness or being filled with madness. And here, Spanish speakers asked to, we're told a narrative of Laura, who was either entered into locura or was filled with locura. And then how people think that Laura is going to turn out. If she if she entered madness, then she had a higher likelihood of recovery than if she had been filled with it. She would be more disabled if she had been filled with madness rather than had entered it. And she would get more support if she had entered rather than was filled with madness. So these I mean, there can be dozens of examples of how language really is important. And as an editorial, slightly snarky aside, I find it interesting and alarming that the profession of psychiatry continues. I mean, the psychiatry who should be most attuned to the power of words to shape ideas continues to use terms like, we'll say, borderline personality disorder or personality disorder in general, which clearly describes the problem was with the person, not due to, some biochemical imbalance or something like that. And since I'm on this little riff, the whole notion of treatment-resistant disease is, I just want to point out, has some problems to it, because when you frame, when you describe a person with depression who has not gotten better with standard treatment, and we characterize that person as having treatment-resistant depression, that seems to frame one's thinking that the disease has the person and that the disease is like ordinary depression, just worse. Whereas it might be reasonable or reasonably equally accurate to think that we have failed to adequately diagnose the individual, or that the treatment, that the treatment that we offered was incorrect, but the treatment is still responsive, the person is still responsive to treatment if we simply chose a better treatment. So labeling illnesses as treatment resistant, I think subtly takes the blame and the responsibility off of us and puts it onto the mysterious disease. So back to the scheduled programming. Chemical imbalance. I had the benefit in my training in psychiatry to have been mentored by a significant number of people who were psychiatrists whose memory of psychiatry in practice went back to the either the pre-pharmacology era or the era when medicines had been recently introduced. And what they told me is in line with some of the histories of the profession that I've read. And that history regarding antidepressants is quite interesting because when the antidepressants, first we had MAO inhibitors and then tricyclics. By the 1960s, we had both MAOs and tricyclics. And it would seem from the eyes of the industry that we had made great strides in the treatment of depression. Yet for all the importance that depression has, American psychiatrists, and it was particularly American psychiatrists, were not really prescribing these medicines, and it surprised everybody. The in American psychiatry in that era, psychodynamic theory was still predominant, and most clinicians dismiss the idea of medications because how could a few atoms of some kind of exogenous molecule have, I mean, how is that relevant to ego, conflicts, and defense mechanisms? So the thinking at the time was that mental forces are very much separate from the processing of the brain, and it seemed improbable that manipulating chemistry and somehow would have any relevance to the what was widely known as the real issue, which was defense mechanisms related to id and superego conflict. Um, that changed very dramatically within a few years after NIH scientists identified that antidepressants had an ability to interact with the reuptake of monoamine neurotransmitters such as serotonin, norepinephrine. Well, those are the primary ones that they were looking at that era. And that led to the phrasing of chemical imbalance. A chemical imbalance came out of that because then apparently you simply had to tell doctors, yeah, well, they manipulate serotonin levels, and that was sufficient to get the doctors to prescribe it. And as David Healy points out, it was the quote, the right measure of simplicity and ambiguity. It had the feeling of an explanation, even though as an explanation it was very, very, very fuzzy. But it was sufficient to give rationale to doctors to prescribe medicines. And then on the right side of this slide, as you know, they've been not only were physicians marketed or instructed or educated, as we say nowadays, they were given, say, continuing medical education credits at national meetings, which is one of the ways that the industry works, to talk about new findings in the field of depression. So, the industry script is to educate doctors about the latest science, provided the latest science is supportive of prescribing practices for that particular drug. And in terms of marketing to consumers, then we have here this interesting direct-to-consumer ability. And here's a selection of various quotes on the right side of the screen showing how consumers were educated about more or less chemical imbalance. So it became, widely known and seems to make sense. We're told antidepressants work. Antidepressants are chemicals, and it makes sense intuitively that they must balance something that was out of balance before. So that's all great, except for going back to words and narrative have very substantial impacts on how doctors view treatment, how patients view themselves and their futures. And here are some, we could say, unintended consequences of the dominance of a chemical imbalance explanation. By phrasing widely the concept of depression as a chemical imbalance, it de facto minimizes or completely makes irrelevant consideration of things like relationships, jobs, purpose and meaning, values, autonomy, feeling whether you're powerful or powerless, and so forth, which is really quite curious because we've known for, I think, all of human writing that all of human thought in written form, that things like that are actually highly relevant to well-being. And then if the industry and the profession tell the insurance company and the government that depression is a biochemical disorder that is served by biochemical treatment, then you have the entire system of care is geared toward questionnaires and prescriptions and 15-minute follow-ups. Because if depression is just a matter of finding it and treating it and correcting the alleged imbalance, then honestly, what more would you need to do? And I have been in meetings with important healthcare administrators at state and national levels where I've heard talk with great seriousness, unironically, that perhaps we can do a better job of getting the epidemic of depression under better control by simply having more access to pills. Snarky aside again, I know that Nicole likes these parts. It also strikes me as odd that we have, if you look at the number of medications available, the number of people covered by insurance, which includes mental health care, the number of psychiatric treatment facilities, both outpatient and inpatient, the amount of advertising and the reduction of stigma around a condition such as depression, you should think that we are really kicking depression's butt right now, because there's never been a better better constellation of infrastructure elements in all of human history. But if you look to real world data, you will see that every generational cohort born since the 1950s has higher and higher prevalence of depression. The last I checked, suicide rates were at or near all-time highs, and the prevalence of depression has barely budged, if not increased overall. So it's, I think in the minds of some of the administrators that I've heard speak, that simply means we're not doing enough of the things that we've already got. But I think if you want to be truly open-minded and scientific, you have to ask some hard questions like, one, maybe these things actually make the problem worse. I mean, I'm not saying that it does, but that's a hypothesis that needs to be seriously considered. Or what I truly believe is that the concept of depression is inaccurate or overly simplistic and doesn't adequately account for what depression actually is, which is, in my view, something far more than a chemical imbalance for many, many people. Um, but nonetheless, chemical imbalance justifies the current model. And okay, sorry about this part, but my heart breaks every time I hear of a young person who's diagnosed with anything, but particularly something like depression or bipolar disorder, um, because, and to be clear, I mean, this can happen to youth. I'm not doubting the validity of many of these diagnoses, but I think that that diagnosis plus a narrative of you, young person, are a chemically imbalanced person, and for you, a road to a content and peaceful and somewhat and a life that offers some chance of happiness involves the taking of drugs, is a risky proposition because during adolescence and young adulthood, one of your major jobs is to form a sense of identity. And if your identity is given to you by this profession or this industry as biochemically imbalanced, I don't think anybody has any idea what the long-term outcome is going to be to individuals and to society from creating a large cohort of individuals that have been instructed that they are biochemically imbalanced and require biochemical solutions. Um, the where oh this is a duplicate slide. Sorry. Related to that, I mean, it related to the idea that I just expressed. Teaching people with depression that their depression arises from biochemical imbalance is in some ways disempowering, and it minimizes the relevance of their thoughts, their beliefs, or their lack of beliefs, or their sense of autonomy as a person. I'm a little bit frazzled now, so I don't think I put this other thing in, but I've also seen a number of cases where, oh yeah, discredits the perceived value of non-pharmacological treatments. By that, we'll say counseling or therapy. And I've seen, I mean, firsthand, I've had a number of interactions with psychologists or various kinds of therapists who I would think are devoted to the idea that psychotherapy is an inherently powerful and relevant and important treatment plank. And after a relatively short time of seeming non-results, it's thought that the problem is with the biochemistry and not with the therapy. So it strikes me as odd that a number of therapists or psychologists sort of self-discredit themselves when they give up relatively early and say that the person needs to have some medicine. Um, that happens, it seems to me. The other thing that happens in a chemically in a chemical imbalance dominant narrative of depression is that when depression treatments fail, we again tend to think about, well, and this is the problem again with the concept of treatment resistant depression, we need to just treat it harder. So people will get different biochemical agents or higher doses of biochemical agents or mixtures of biochemical agents. And from my consultation work with a lot of people who have not responded to long terms of treatments, those increasingly exotic pharmacological interventions are rarely matched by increasingly detailed psychological inquiry or psychological treatments. And so that produces a great deal of harm. And also it aids, as I wrote in the slide, aids and abets the the person to avoid thinking about things that might, in some cases, be actually the problem. Anecdotally, I once was asked to consult with a patient for ECT. Both the patient wanted electroconvulsive therapy and his doctor wanted electroconvulsive therapy because he had was said to have treatment-resistant depression. And as I spoke with him, um, in response to a question that I always ask, like, um, tell me about times in your life, if ever, where you were not depressed or less depressed or happy. And in response to that question, the patient gave me a number of stories, which made me then ask the following question. And it was really, it sounds outlandish to say it out of context, but I did ask him this. So are you, would you say that if your wife would leave you alone or let you gamble or have girlfriends, then your depression wouldn't be an issue anymore? And he said, yeah, I think that's true. Because his depression lifted when he was away from his wife, and it always came back when he was with her. And his wife controlled all of his finances, and kept him from having what he perceived to be any kind of fun. He was astounded that I refused to give him ECT, and I got a nasty note from his doctor as well. Um, and this is an example of what I would call aiding and abetting illness behavior, because that clearly, if his relationship wasn't the primary driver of his depression, it was certainly a massively important component of his ill mental health. And the fact that apparently I was the first person in years of engagement with treatment to ever bring that up means that he suffered, well, he was exposed to drugs which did no good and thus produced the possibility of harm without benefit. And he was not instructed for that many years to look at and consider things that might repair or improve his interpersonal relationships. And so if we do this at scale, we have a large number of people who get stuck in jobs that actually cause their depression, and they're not counseled or led to think that maybe I could do something different, or learn assertiveness training or learn a new skill. Similarly, with their relationships or with their recreational drugs or with their lack of purpose, there are many, many, many pathways to depression. And unfortunately, all depression looks the same once it is there. And not even though all depressions might look the same or feel the same, not all of them have to do primarily with serotonin deficiency. And I think it's just worth pointing out that that's a thing. So now let's turn to some other ways of looking at depression. Some depressions, actually in evolutionary psychology, depression is thought to be an adaptive response. Within the framework of evolutionary psychology, your brain, as I said, is viewed as a primary survival tool. Like your brain's job is to promote your survival. In this framework as well, emotions represent one of your brain's tools to ensure your survival. In this world, we have then two primary motivators. We are motivated to acquire, to move toward and acquire things that will promote our survival, and to avoid or solve problems that might imperil our survival. So most emotions then are within a reward seeking or a threat avoidance family. And emotion is seen as a constellation of physiological and cognitive changes, which create a state which both motivates the organism to either achieve rewards or avoid threats, and to become more successful at acquiring or avoiding those survival relevant things. In evolutionary psychology, depression is seen as a signal from the body, a motivational response or a demotivational response in this case, to situations in which energy is being expended without adequate return. So it makes sense if you're going to, if you're supposed to collect berries, and eating berries gives you sustenance and reward, then you are content or happy. But if you are focused on acquiring sticks, and then you'll find that you are not eating well, and then you are stressed and depressed, and this would be in a simplistic way of saying, let's stop the stick gathering and try a different strategy. So depression is intended in this view to be a signal that we need to reassess what we are aiming at and to aim at something that is going to be more fruitful. And depression also, in evolutionary theory, um, involves outward changes of affect and behavior, which is supposed to elicit social support, because the other aspect of human survival is that it is a team effort. And so depression is a way to signal to people in your team that you need some attention. And in that regard, for many people, seeing depression as a signal that maybe there's something in my life which is not quite right, and maybe this is my opportunity to step back and reassess um, where I'm aiming and what I should do. Depression is, in that view, seen as kind of like a friend in some way, or at least not a chemical imbalance enemy that you can't control, that rather sort of grips you and places you at the mercy of finding the right doctor to do the right chemicals. Um, Depression is also, I mean, now going back from the theoretical to the really, really real and easily measurable, depression involves changes of cognition, and people who are prone to depression seem to have tendencies or cognitive habits which may lead them to depression. Notably, people with, there is, stepping back, um, we're filled, all around us are events and stimuli, and within us are memories and feelings as well. All of these are inherently neutral. Our brain assigns positive or negative emotional value to them, or no value at all. So the brain can sort things into related to survival, thus interesting or relevant, um, or engagement feeling, positive emotion. Things can be perceived as threatening to our survival, so those would be negative emotions, and a whole bunch of what happens is just neutral or irrelevant, and and our brain processes that behind our awareness and makes us unaware of them for the most part. But for things that are neutral or slightly positive, there's a tendency that the brain will overweight the positive assignment of emotion to it. So if the thing is like, if a thing is, say, an empty cup, which may be relatively neutral, my brain is likely to assign a higher positivity value to that to engage me to explore it. That would be advantageous. And if I encounter something that represents possibly a threat or a negative stimulus, my brain will actually overweight the importance of the negativity, because it's more important evolutionarily to avoid threats and to acquire gains, it seems. So there's a natural human tendency for us to overestimate the positive value of things that are neutral or only slightly good. And there's a tendency for us to overweight the importance of things that represent threat. People with depression, it turns out, have a relative deficiency in recognizing positive thing or in assigning positive emotion to neutral or slightly neutral things. And they have a tendency to extraordinarily overweight the importance or the relevance of negative things. So I sometimes simplistically call this a memory imbalance, or sometimes I say depression can be seen as kind of like an Alzheimer's disease when it comes to remembering good things. And that is, I mean, again and again, people have shown in various neuropsychological testing paradigms, people with depression are better able to recognize potential threats or negative stimuli, and they tend to ignore or not remember positive stimuli. If you get a bunch of people with depression and a bunch of people without, and give them a list of words to remember, you'll find that both groups can remember 12 out of 20 words presented to them. But if you insert in that list positive affect words like sunshine, friendship, or love, or negative affect words like prickly, hard, or enemy, you will find that even though the depressed person has no overall memory impairment, their ability to retain positive affect words is significantly reduced, and their ability to learn and remember the negative affect words is significantly increased. this, I think, is very interesting because number one, we can measure that again and again and again. So as opposed to chemical imbalance, which remains eternally nebulous, um, cognitive imbalance or memory imbalance is very reliably demonstrated. And then that opens up um, the possibility that the patient themselves could be more in charge of their recovery by learning to practice mindfulness of um, that I might tend to overweight negative things, and I might not want to do that so much, or I might want to pay more attention to the possibility that there are actually some good things in the world. As I've told my patients many times before, the person with depression is usually quite accurate in recognizing things that are representing threat or the things that may be wrong. Um, and although they may be accurate, there's a lot of sadness in the world. There's also a lot of happiness and opportunity and beauty in the world as well. So I typically will invite people to just notice that things, that nice things exist. And I haven't seen this the following I sort of adapted from positive psychology. I haven't seen it done in depression therapy itself, but I will typically recommend to individuals, both depressed or anybody who simply wants to maybe have a better shot at a contented life, that you could introduce a practice of keeping a journal, call it the one good thing a day book. And my instruction is at the end of the day, just think about the day and write down one thing that was good about it. And my intention for doing that is to introduce attention bias modification. So if you know if you know at the end of the day that your job is to write down something good, then you are a little bit more on the lookout for things that you can put into your book. And over time, that might have some benefit. And in the worst case, it gives you a nice diary of a nice life. But hopefully, it does more than that. And we can also, seeing depression as a cognitive imbalance or a memory imbalance or an attention imbalance, also reiterates or reaffirms the importance of psychotherapies which are directed at fostering mindfulness or at examining thoughts. And I mean, cognitive behavioral therapy, mindfulness-based cognitive behavior therapy, acceptance and commitment therapy. These are all therapies designed around these concepts of cognitive imbalance. And if more people understood that depression involves these sorts of things, it would give significantly more legitimacy to these very good evidence-based psychotherapies and might stimulate the development or the redevelopment of a mental health care system that emphasizes the importance of that. So those are some thoughts about imbalance and my little attempt to try to put depression into a little bit of better balance.